Today we'll be discussing about the predicting and monitoring the risk of decompensation and mortality in alcohol-related liver disease. To look as the natural progression of the disease, we find that the compensated stage, it stays for long, or in fact, it is the time when the risk factors could be removed or even the disease etiology could be taken care of. But once the patients decompensate, there is a rapid progression. And it is important to discuss about the alcohol-related liver disease because there is a huge global burden. The global prevalence of compensated cirrhosis is up to the tune of 25 million, and decompensated cirrhosis around 2.5 million. And when any chronic liver disease, especially the alcohol-related liver disease, is compared to a chronic etiology like diabetes or cancer, it is seen that the mortality is nearly 1 to 2 decades earlier as compared to diabetes or other diseases. Even the ILBS experience with alcohol cirrhosis has been same, where we find that patients who have alcohol-related cirrhosis compared to non-alcohol-related cirrhosis, there is higher death at the index admission. There is also more frequent readmissions and death during the readmissions. The median time to diagnosis of cirrhosis to index hospitalization is around 2 years, with 1/3 of the cirrhosis patient die within the index hospitalization itself, and nearly 60% of the alcohol-related cirrhosis survivors, they require at least one more hospitalization within a year. So what should be the blueprint for early action in ALD? The most important thing is treat the cause, that is alcohol abstinence, and also early detection and screening for ALD, and where the role of non-invasive testing comes. That is the FIB4. We'll be discussing in detail about FIB4, the LSM monitoring, LB score, and ELF. Also, we need to understand that the screening should be easy, right from the population level to the tertiary care centers, and where we stand as far as the technology currently is there, and how we can take maximum leverage for our advantage. When we look at the non-invasive determination of compensated advanced chronic liver disease, Bevino has given a very simplified guideline that anything less than 10 kilopascal probably exclude compensated advanced chronic liver disease, and more than 25 consider for CSPH. More than 10 suggestive of compensated advanced chronic liver disease, and anything more than 15 is highly suggestive. So as the disease progress, the non-invasive testing have maximum role when patient is in the disease progression before they decompensate or there is any liver related event occurring, that is development of HCC. So why alcohol abstinence is important when we discussed alcohol liver disease? In this systematic review and meta-analysis, what was studied was the effect of abstinence from alcohol on survivals. 7 studies with 1,235 patients, all alcohol cirrhosis, and it was seen that up to 1.5 years there was near significance benefit of abstinence, but after 1.5 years of abstinence, there is improved survival at every time point. Also, in the another study where 15-year Norwegian patients were followed up with alcohol cirrhosis, they had decompensation at the index presentation. The first year mortality is 49%, but as the follow-up continues, what they found that even the minimal amount of alcohol intake had poor outcome. Another cohort study of 122 patients where it was found that survival was not only associated with alcohol intake, but even smoking aggravates and alcoholic hepatitis because of disease-specific etiological measures, disease-specific treatment measures had a better prognosis. There is also another study recently published where individualized approach of liver-related death was studied. In the derivation cohort, there was around 566 patients. The median MELD was 9, child B, most of them child B, and they divided into consumers and non-consumers. That is, once the diagnosis has been made, then nearly 169 patients were abstinence, and 338 patients, they again continued to drink. And it was found that liver-related mortality was associated with lack of abstinence, advanced CTP, and age. And in this nomogram, they clearly mentioned that for the same CTP level and same age, the risk of death is nearly 2 times in patients who consume alcohol, that is around 20% if we see this dark orange line, compared to this yellow line, which is around 10%. So where we stand for non-invasive testing, I'll be starting with the LB score because it is an very important score. Over the years, it has progressed from an HCC monitoring to the monitoring of the liver dysfunction. Could not find a dedicated study where LB was studied for alcoholic cirrhosis, but in retrospective study where all etiologies of cirrhosis were considered, decompensation in 72% with alcohol-related cirrhosis in around 45%. It was found that factors associated with mortality was LB, MELD, sodium, and age. Decompensation was associated with LB and age, and LB score had a better prognostic indicator of mortality than CTP or MELD sodium. Another study also with all the etiology, 53% at baseline had ascites, and it was found that HVPG and LB score had the best correlation, and also LB was independently associated with prediction of survivors. Then another study where alcoholic cirrhosis, it was found that the performance of LB score was comparable to child and MELD scores, and it has also been studied in various other patient profiles. It is not there. This study was based on the correlation of liver stiffness with NIT, that is FIB4 and NFS. And in this study, what they have studied in the general population, that there is a intrinsic false negative and false positive estimation of FIB4. The at-risk cohort out of 5,129 was 1,150. Nearly 30% had alcohol-related risk and others had NAFLD-related risk. And the proportion of false negative was higher in the at-risk population as well as in the general population. And what they found that FIB4 or the NAFLD fibrosis score nearly overestimated in 28% or 1/3 of the patient to have advanced fibrosis. But this deficiency was in another study when they found that in the general population or even at the at-risk population, FIB4 alone, which only correctly classified in 63% of the patient with having LSM of more than 8 or more than 12, but when it was combined with ELF score, it improves to around 88%. So we come to ELF score where it was studied that it predicts hepatic decompensation and mortality, and in the NHS study where it was a population-based study which is called the ILFT or Intelligent LFT pathway, where the primary practitioners, if they have deranged LFT, then they take a decision for referral. Out of this 1,327 patients, alcohol-related liver disease was in 30%, median ELF of 10.2. ELF score, it consists of hyaluronic acid, procollagen 3, N-terminal peptide, and TIMP1. The ELF data was categorized into more than 9.8 and less than 9.8, and it was found that high ELF was seen in around 64%, with 95% were correctly classified to have cirrhosis. And even in alcohol-related liver disease, around 88.9 or nearly 90% of the patients were correctly labeled to have cirrhosis based on this non-invasive testing. When they studied the ELF with FIB4, it fared considerably better as compared to FIB4. And for every unit rise of ELF score, the decompensation is, there is 2 times higher risk of decompensation and liver-related mortality. And when ELF of more than 13 was associated with particularly high risk of decompensation, that is within 90 days, nearly 1/4 of the patient will have decompensation. And if at baseline ELF is more than 13, then all-cause mortality within 1 year could be nearly in 1/3 of the patient. In this study where the Finland population in 2000 and 2001, the samples were collected and these patients were followed up for around 13 years. Less than 7.7 ruled out liver disease, more than 0.98 it ruled in an advanced fibrosis, and more than 11.3 rule in for cirrhosis. Alcohol users were nearly 79%. Lifetime abstinence were in less than 10%, and the mean ELF was 8.85. When ELF was seen as a continuous variable, it was seen that at baseline, patients who have a higher ELF score will have more liver-related outcome within 5 years. And ELF also had a good prediction as far as the liver-related outcome and the incident. The ELF of more than 11.3, it had shown that it has significant association with the incident liver-related outcomes. Then LSM, where repeat measures of LSM, even the Bevino guideline says that within 12 months it should be done. In this study, where 536 patients of 2 cohorts, median follow-up was around 13.1 years, with median LSM at baseline of 8.1 kilopascal. They divided those patients who had follow-up LSM available, 371 out of 536, they divided into LSM increases, decreases, stable non-severe or stable severe. So what were increases? As the Bevino defined, that anything more than 20% from baseline. Decreases were less than 20% of from baseline or any value less than 10 kilopascal. And stable disease where they don't achieve an LSM of less than 20. They found that in patients who were increases, LSM increaser, they had nearly 4 times higher risk of decompensation, 3 times higher risk of mortality, and when the combined event was taken, nearly 3 times as compared to decreases. And the factors which were associated with LSM increaser was female gender and lack of alcohol abstinence. LSM decreases were associated with obesity, and when the full cohort and all decompensation were taken, it was seen that a high GGT, high LSM FIB4 and melt sodium was associated. Then few more population-based prognostic studies. This is the Clived score, where the population cohorts from 3 different countries of 20,000, nearly 25,000 individuals, derivation of 8,100. Average drink were 8 or 13 or 11 in different countries, and the Clived score, it predicted the incident liver disease in over 15 years. So what does this Clived D score? It comprises of, there is a nice nomogram which is there, that age, it takes into consideration age, waist hip ratio, alcohol intake and diabetes. There is a specific nomogram where even GGT is not there, but if GGT is available, then non-smokers and smokers. And based on the values, the 15-year risk could be assessed. Then this another study from the European population, where age, gender and 6 lab variables were taken into account, with 23% of these patients, they had high alcohol usage. Liver risk score was calculated with more than 15 as high, and 10 to 15 was high to medium. And it clearly predicted the 10-year liver-related events. Our own study from ILBS by Dr. Ankur Jindal, where he found that the severity of acute portal hypertension, it determines the clinical outcome in severe alcoholic hepatitis, where patients of ACLF, alcoholic hepatitis, were studied, not the alcohol liver disease or decompensated cirrhosis. Patients with more than 20 millimeter of Hg at baseline had a higher MELD, higher incidence of variceal bleed, AKI and SBP. And the 90-day mortality was also significantly higher in patients who had HVPG of more than 20. This novel score, it combines the liver stiffness as well as the lab variables. In this multi-center trial, even ILBS was one of the center for this, and a derivation cohort of around 197 patients. The aim was to study a ready-to-use score for decompensation risk stratification. So the predictors for decompensation was liver stiffness, albumin, varices, presence or absence, and platelet count. And when this, based on this score, patients were divided into low risk, middle risk, and high risk. It was found that it significantly, or it gives a clear estimation of the risk of decompensation in these patients. But the authors have clearly mentioned, or they have considered that the requirement for endoscopy and elastography is one of the main reasons that the general applicability could not be done. Then we come to liver histology, that how liver histology per se may predict decompensation. In this study, where biopsy-proven alcoholic cirrhosis were considered, and they were assessed for biochemical and histological factors, the liver-related mortality at 5 years was seen, and in compensated baseline patients, only 13% liver-related event, decompensated nearly 43%. It was seen that patients who had early cirrhosis, presence of F3, F4, was significantly associated with poor prognosis or decompensation. And in patients who had decompensation at event, lack of pericellular fibrosis or lack of abstinence was associated. Also, another area which should be considered is the estimation of the collagen proportionate area, which in a previous study had shown that it predicts clinical outcomes in patients with alcohol-related liver disease. All these patients were biopsy-proven alcoholic liver disease, decompensation 11%, followed up for nearly 81 months, overall mortality 29%, and digital image analysis was done. It was seen that even in standard magnification or high magnification, there was equal correlation. So all the estimate of the collagen proportionate area was done at the standard magnification. As the stage of fibrosis increases, there was a significant or increase in the collagen proportionate area. And CPA of 16.3%, it predicted the liver-related outcomes. Then few more biomarkers which has been studied in the progression of disease of alcohol-related cirrhosis has been the hepatocyte-derived biomarkers, especially the keratin 18 and the large extracellular vesicles. And it was seen that the incidence of liver-related events over 2 years in child A-related alcohol-related cirrhosis, even in presence or absence of abstinence, was correlating with the absolute keratin 18 value, or when it was combined with the large EVs, hepatocyte-generated large EVs. So as we move on, that what all has been studied as far as the AI or machine learning is there. So an artificial intelligence generated model, it predicted the 90-day survival in alcoholic hepatitis patient. It was a 23-center global study. ILBS was also one of these center. 12 centers for the derivation cohort and 11 centers for the validation cohort. The 3 AI algorithms that was studied was the random forest, gradient boost machine, and the XG boost. And Alchin was the ensemble model that was studied. Also, the parameters that were studied was age, genders, presence or absence of cirrhosis at baseline, and 9 laboratory factors. And it was seen that the predictive model of the AI-generated predictive model of RF, GBM, or XG boost, they had significantly better prediction compared to the conventional MDF, MELT sodium, or EBIC score. This was studied by, published from the Mayo group. Probably don't know how much it would be of further utility, is the ACE score, or the AI cirrhosis ECG studies. And where with the neural network architecture or deep learning method, they found that the A score, that is the ECG changes in cirrhosis as compared to control, was significantly associated with the outcomes. So one of the probably the main area of interest could be the continuous monitoring of variable like fasting blood sugar or ECG for other diseases should be studied for liver-related events. So where we do stand as far as the biosensors or wearable devices for alcohol-related liver disease are concerned, it is still in a very nascent stage. I could find only one study where the transdermal sensing platform was used. There is actually 2 kinds. One is the electrode-based tattooing of the instrument into the skin, and it takes the perspiration. It identifies alcohol use through the perspiration. And another is the micro needles, which take the interstitial fluid from the skin. And the primary aim was very well determined, was very well told that it is the acceptability of the participant to wear it for 3 months. And they also studied in the pilot project whether the wearable alcohol biosensor is useful or not. The TAM, that is the technology acceptance model, subscales, it was very high during the initial days, but it remained high throughout the 3 months. And this probably considers the main challenge as far as the biosensor for alcohol-related liver disease is concerned, is the patient's acceptability for use such devices. Then another the continuous parameter that could be seen into is the proteomic biomarkers. And in this study published in 2022 in Nature Medicine, where paired liver biopsy as well as the plasma proteomics were studied, Out of 360 patients, 94 patients had F3, F4 at baseline, ELF of around 9.3. And the mass spec based proteomic studies and pathways were all studied, and it was seen that the machine learning model identified the proteomic biomarker panel that detected significant fibrosis, mild inflammation, and this could be the area where the continuous monitoring could be assessed. So to summarize, the abstinence of alcohol is paramount whenever going for studying for any alcohol-related liver disease, because it is an individual's responsibility. ALB score monitoring has not been studied dedicatedly for alcoholic liver disease, but over the years it has evolved right from HCC to non-HCC related tumors to determination of the liver function. ELF score, should be routinely used. It has clear advantage over FIB4 or other non-invasive testing. Serial LSM measurements, as shown in the previous study, has its own role, and even Bevino determines that 12 monthly repeat LSM should be done. And big data that could be generated by the mass spec based omics will further enable the targeted screening and therapeutic intervention. And as I conclude that digital application is the new norm as far as the all patients and population is concerned, because it gives a clear opportunity to deliver care remotely, easy adaptability, and to most of the patients, high patient rate is accepted. And thank you.